Volume.
Good evening and welcome to the Ohio Society of Interventional
Echo.
Pain Physicians COVID-19 webinar. The call will begin promptly at 7:02 to allow some more people time to log on. Thank you for joining us, and please hold. Good evening, and thank you for joining the Ohio Society of Interventional Pain Physicians COVID-19 webinar. We sincerely appreciate you joining the call. We are going to start the call promptly at 7:02 to allow a few more folks time to log on. We are very appreciative of you joining us, and we will begin the call shortly. Thank you. Good evening, and thank you for joining the Ohio Society of Interventional Pain Physicians COVID-19 webinar. We are so excited you have joined us tonight. We will start the call now, and I would like to introduce Dr. Ricardo Buenaventura. Take it away.
Hello, everyone. Thank you for tuning in to our webinar. This is the Ohio Society of Interventional Pain Physicians webinar on COVID-19, the Ohio experience and managing through this pandemic. I know there's been several webinars going on the past couple of weeks. With our organization here in Ohio, we wanted to put on one for the state here, covering, not only the experience in Ohio, but also in general terms, what's going on for something that can also help physicians across the country, particularly with telemedicine, coding and billing and financial. So I know we have a packed session today. It'll be about an hour and 15 minutes of several talks. I don't want to delay any further. I'll turn it over to Dr. Humam Akbek, who'll give us a medical introduction to COVID-19.
Dr. Akbek, we can't hear you. Can you turn on your phone, please?
Thank you very much for joining our Ohio Interventional Pain Society webinar. This is designed for Ohio and the neighboring state to be able to handle the pandemic that we are in and how we can continue our practices. You will find very specific topics, and I believe that it will address a lot of your concerns. I do not claim that I am the world's expert in COVID, but I wanted to look at the COVID-19 in a different way that really relates to our practices and help us make decisions. Let's go to the first slide, please. Can you push next? I cannot control it. Okay, so at the beginning, I would like to address what exactly COVID-19 and relate to others. Many people would say that COVID-19 is exactly like the influenza, which is, I am not sure if that's really the, Can I see the slide before that, please? I can't control it really.
Dr. Akbik, there's about a 1 second delay. So I will get to the first slide for you, and then that way you'll be right on.
All right, wonderful, thank you.
Do you want to go to the next one?
Okay, just start with the first one, and then we'll go from there. Okay, perfect. So pandemics are not new to human race. We have been through this about 100 years ago, in 1918, 1914, we had the Spanish flu. And unfortunately, at that time, about 50 million people have lost their life with that pandemic. Then we had SARS, we had MERS, we had Ebola, and all of them, the difference between Corona or COVID-19 and those is that COVID-19 has a much slower spread, but also is a little bit higher mortality since it hides when it spreads. And what does that really affect us? Because if you look at the data, it always shows you that it's about 1 week behind. And the curve is about 8 weeks before the curve really develops. So what we know right now, they put different models. And if you look at the London or England model, England had done different models. One model is that let's do nothing and do the herd immunity. And you would see that the curve was pretty drastic of how many people will be critically ill in Great Britain. And then they said, what about if we do close the school? What about if we do the case isolation? And what about if we can do just the country shutdown? And if you notice that the more isolation, the better the curve and the earlier we'll be able to get out of the pandemic. So what does that really tell us? That tells us is that any country who did the isolation did much better than the countries have not done the isolation. We have different models actually for the isolation. We have the first country that was China, and now Wuhan is back to work, and everybody is waiting for the second peak to see if there's going to be a second peak. The reason why we don't know how exactly this is transmitted. Every few days you will find a new theory of how this virus is transmitted. What we know it's not airborne, but we know it's now really respiratory droplet. And there's one article said that if somebody sneezed in a room and left the room, and within 15 minutes, if someone else entered that room, might be able, he may catch the coronavirus, even though there was not a hand-to-hand shake, or there's not even less than 6 feet distance between both people. So when we look at the mortality rate, influenza is about 0.1%, but COVID-19 is 10 times that, which is about 1%. Age-related, any up to 40 years old, it's 1%. If you're 50 years old, 2%. 60 years old, 4%, 78%, and 80 and above 15%. So if you notice, it doubles every decade of age. And the patients who have more of a cardiac or blood pressure or diabetes, they usually are more vulnerable to be more sick and end up in the ICU. Now, where to treat? And this is another model, is that we have here a little bit chaotic in the United States, unfortunately, versus Europe or versus Asia. Here, every single hospital in the state almost has patients of COVID-19. In China, they build dedicated hospitals. Italy, Spain, England, now everybody's making dedicated hospitals for COVID-19. In the US, that model was not adopted. Every hospital is accepting COVID-19, except here, we have a similar model in Toledo, Ohio, where Medina, I think, healthcare has decided that they want to have their own one hospital COVID-19 dedicated, since it has one of the best ventilation systems. So I believe that model might work much better than other models. And who and when to test. has been all over the news. Every single media person is asking about that. Well, we can see different models. In China, they really shut down the city and they tried to do the test on every person. In South Korea, they shut down the whole country and they start testing every single person. And what they did now in Germany, for example, they are testing as many people as they can. And if you have a COVID-19 positive and recovered, you get a certificate, so you'll be allowed to go back to work. In Italy and in Spain, right now, everybody's isolated, and only people who are allowed out to do specific tasks are the negative or the positives who are recovered. So basically, really testing, it looks like the more testing we do, the better we'll be able to have more control over this. So how to test? And basically what you do, you need to test as many people as you can. Isolate the patients that they become positive and maybe treat it. Now we know that, again, the hydroxychloroquine treatment, the zinc, the azithromycin combination has been used widely in Italy, in Spain, in Germany, in France. Even now in France, they're using the plasma from recovered COVID patients. So basically, the treatment, that's the only thing that we have available. But that's how the closed loop is becoming in Europe and other places in the world. And then when you recover, you get released, you get the certificate, and then you can go back to work. So we go back in again, and we find out the test is any patient who have symptoms need to be tested, and actually any person who can be tested, if we have enough tests, needs to be tested. We talked about the treatment. This is the current treatment that we have. Besides the plasma, that's what we have. And actually the ultimate treatment is the vaccine, and that hopefully will be within 1 year. So we have to be able to sustain about 40 to 70% contamination rate, or people who will have positive for COVID-19 until probably 1 year from now, where 70% of people will test positive. Everybody's talking about the masks. And well, let's talk about the masks, because it's important for all of us to understand what exactly the masks are. So the masks here, let me go previous.
I can get it for you.
The masks. Okay, thank you. The masks are, we have the N95 mask. The N95 mask is about 100% of the bacteria and control about 95% of the viruses. And then you have the surgical mask. The surgical mask is actually, it's a very good mask for the viruses as well. It's almost as good as the N95 mask. It's about 95%, but the bacteria is much less. Then you have the sponge mask, which is actually 0 for the bacteria and 10%, 0 for the virus, 10% for the bacteria. And then you have what we call the cloth or the scarf. And the cloth or the scarf does not really do anything, except that if the patient is positive for COVID-19 and cough or have droplet, that would hold it and will decrease the possibility of contamination. So it actually does not protect the person, it just protects the person across. Now we have different models has been in the world, and we have the China model where they had the whole city quarantined. We have the South Korea model where they tested everybody, and if you are positive, you stay at home or you go to the hospital, and if you're not positive, you stay out. We have the Germany model where they tested everybody, and if you're positive and you recovered, you go to work. And then we have the US model, which is basically there's no model in the US. Unfortunately, we don't really have any unified policy of who to test, when to test, what to test. Even physicians cannot be tested. So really it's extremely chaotic, and that's why it's so hard to be able to build data from the US model. So many people say we are restrained, we have no money left to buy anything. What would I buy? Would I buy PPEs or would I buy more tests? Well, if you look at it, if you have money to spend, I think it's better to buy testing, because the more people you test, the more you can isolate. So rather than have many healthcare worker wearing PPEs, you can isolate those patients in one area and have dedicated staff take care of those patients. And I can tell you that one patient in the isolation utilized about 36 pairs of gloves per hour. So basically, the utilization of PPE goes really exponentially high. There's few myths about COVID-19 or true. We don't know yet, but hopefully it will come. We have countries that the rate of COVID-19 spread is extremely low and the mortality is low. They say because many of those people around those countries is positive or has been vaccinated against TB with BCG. Examples, the Middle East countries, even though it's much more crowded and it's very hard to quarantine, but most of them, they did not have the high contingency that we had here in the US. People say it's like flu. It's not like the flu. People say the malaria treatment. And I'll give you some examples. In India, there's 1.3 billion people in India. They have 3,082 people confirmed positive, and they have 213 deaths. Nobody can explain this. They are quarantined like the US, but also they think that because many people have been treated with malaria-like drugs, they don't have much mortality rate. Long-term immunity, we really don't know anything about the long-term immunity. We know that you get immunity, but we don't know how long that's going to take. People say maybe it's less than a year, more than a year. We really don't know. One of the myths that runny nose and sneezing is part of the COVID-19. It's not. Cough and fever. Cough is now becoming the hallmark rather than the fever, since the fever takes lag behind. So patients usually start coughing, start with myalgia, body ache, a little bit of difficulty breathing, and then actually the fever kicks in. So fever is a late sign rather than an early sign of COVID-19. People say the warmer weather will kill the virus. That's a myth. Eating a lot of garlic, that's a myth. The only thing that will really bother your colleagues, even if you're 6 feet social distancing. If people say you have to drink water every 15 minutes, that's a myth, nothing proven. And people say silver water will protect you. That's also a myth. And people say that if you eat a lot of ice cream, you will be more prone to get the COVID-19. Is an absolute myth. So my final point is that this virus is a human and economic virus. We've never had anything like this. Both humanity and the economy are paying the penalty right now for this virus. We have an 80-20 rule. We have 80% of the people are paying attention and they're following the rules of staying at home. We have 20% of those people who are not following the rules, and unfortunately, they are the reason why the curve is just not flattening. We have the 1-3 rule. We have one person can contaminate 3 people, except this rule changes. If you are in a church, this rule goes 1 to 17. So rather than only infecting 3, your rate in infecting people goes up to 17. So unfortunately, there's some churches are still having prayers on Sundays, and this is really it's going to be a hot area for contamination. Recovered patient, long-term sequelae. We have some memory problems. We have some long-term respiratory problems. We're not sure about it. We are sure economically that there will be an international travel will suffer for a long time. We know that restaurants usually keep 15 days of reserve financially. Health facilities like ourselves, we usually have 30 days to 60 days backup. A real estate 45 days. So if this thing start lingering more than 30 days or 60 days, the economic effect will be tremendous. And I would like to share my last thought. We are all in the same boat. And even if you own half of the boat and you start drilling in your end, the whole boat will sink. So we are all in this, and we really have to help each other doing this. Thank you very much.
Wonderful. Dr. Soin?
Yes, hello everyone. Good evening, and thank you for the time today. I'm going to be talking to you about the Ohio government and the Department of Health response and share some vital statistics that we have regarding the virus.
Dr. Soin, you went back on mute, unfortunately.
Thank you. Sorry about that, everybody. You can see in the state of Ohio, we have 4,043 confirmed coronavirus cases. You can see some of the major cities or hot spots there, Toledo, Cleveland, Akron area, Columbus, and Cincinnati. And to look further at the vital statistics here, I'm going to advance to the next. Be able to advance the slide for me? You can see here the daily increase in Ohio's confirmed cases. And one thing that you see that's interesting over the past 5 days is relatively leveling off. Who knows about that one data point on April 5th, only 304 cases. The key thing on the bottom is looking at the percentage of new cases per day. And it appears at least to be that we're somewhat leveling off over the past week or so. Can you move to the next slide, please? You see here from March 8th to April 5th, you can see the curve here ramping up, similar to what you see in all of the TV shows on CNN and the newscaster reports, and you can see our steady increase. Now, where the curve plateaus varies from opinion to opinion. The initial projections said we were going to plateau around May 1st. Now they're saying it could be around April 16th for us to flatten the curve. Can you move to the next slide, please? And here you can see the map filling in from March 13th through April 5th. And you can see the states of Ohio steadily filling in there. I want to compare ourselves to Michigan, right? Because Michigan's very similar demographically. You can move to the next slide. Michigan's very similar demographically to Ohio. And you can see what happened there, right? You see an extensive ramp up for Michigan, where they're at now, and Ohio's ramp up is significantly slower. This, of course, is due to Governor DeWine and Amy acting early with social distancing. We were the first state to close schools. They actually closed and stopped doing the Arnold conference in Columbus, which they were saying that alone prevented a significant outbreak, as well as they suspended all of the state athletics and school athletic competitions, including college basketball tournaments and events in the state of Ohio. And actually, Governor DeWine did this before there was even a confirmed case in the state. Awfully aggressive, but look what it did to our curve. Please move to the next slide. Here's another graph comparing us to Michigan, and you can see significant ramp up in Michigan compared to Ohio. So generally speaking, Ohio seems to be doing very well compared to Michigan, and a lot of it's due to social distancing, physicians following the rules. And here you can see, again, comparing Ohio to Michigan, cases per 100,000 and deaths per 100,000 significantly lower. And you can move to the next slide, please. And I'll turn it over to Dr. Sachdeva.
All right. I think thanks for listening to us today. I'll be talking about the Urban University response. I work at University of Cincinnati. And as we know, University of Cincinnati is a tertiary care medical center. It is a level 1 trauma and an educational institute. So we, within a big hospital, if you're working in a big hospital like University of Cincinnati, you have to look at different aspects, starting from the ambulatory services to the inpatient services. And the most one is the graduate medical education too, where we take care of the residents, fellows, and the medical students too. Overall, there are a lot more task force which are developed within the system, but I'll dwell on a little bit, starting with the ambulatory. Ambulatory task force is responsible for the outpatient clinics, which most of our pain physicians have outpatient practices. And the ambulatory task force comprises of medical directors and the business managers. So we have a call. We started doing meetings once a day, every day. We have a webinar, or we talk to what are the daily problems within the outpatient settings. Early in the March, as the as we saw the disease was progressing, this task force was set up. Initial guidelines were how do you deal with the patients. So we started off with sending out a patient questionnaire a day before all the patients were called, before they came to the clinic for the appointments. And we were asked those 3 golden questions, which everybody has been asking. Actually, it's 4. Any symptoms of cough, shortness of breath, and fever. And along with that, any history of travel to the endemic areas. Actually, we have gone away from asking that endemic question because anybody has symptoms is considered to be COVID positive. And then as we saw that more patients were being treated for COVID, we moved to telehealth. Pretty much all the services in the outpatient have moved to telehealth unless you really need to see patient face-to-face. Face-to-face, you can do a video conferencing, but if you can't, then once in a while, it's an emergent patient you might have to see in the clinic. So that is a really important factor for us. Can we go back to the previous slide? Yeah, thanks. So then, you know, as Governor DeWine said that there was a lockdown in place and the schools closed down. So all the employees who have young kids, what do you do with the childcare support? So UC Health actually collaborated with the YMCA and provided the daycare services for most of the employees. And it was very nice of UC Health, at least 50% of the cost was taken by them, and they were paying for 50% of the cost for childcare. Started setting up some drive-through clinics. It was, again, you know, it's a very unique situation which nobody has seen or in the past. And as we all know, the kits were in short supply. So the drive-through clinics have started initially for mostly first responders and the healthcare providers, people who work in the UC Health. And you need to have an appointment to go through the drive-through clinic. But as the kits became more available, we started doing a lot more. But you still need an appointment to go through those drive-through clinics. Then you have to set up, the HR needs to look at the employees, how do they work, the employee processes for sick employees have to be set up. Everybody was initially really, all the employees were encouraged to not come to work if they have any of those symptoms, and then call the employee health and they would set you up for COVID testing and maybe self-quarantine for 14 days. And then as the COVID becomes more prevalent, now we are actually testing temperatures of every single employee who walks in the hospital in the morning. So that at least gives us some idea, and we are taking care of that the employees are not the ones who are spreading the disease. Work from home policy was set up, so we really try to see as many as employees who can work from home can do that. You know, you still need to have a policy for it, make sure that the employee is still productive and they're working from home. They have a network available and no distractions at home. The telehealth, you know, somebody's going to talk about telehealth in detail, but I can tell you that we really are actively doing pretty much telehealth every day. And last week within the UC Health, maybe we had more than 10,000 telehealth visits. All right, next slide, please. All right, then, you know, the second task force I'm going to talk about, the inpatient. As we know, inpatient has a very important role to play in the whole thing, the hospital and the ICU task force. We have to prepare for the surge. There are models out there. We all know where we are. According to what we are looking at, the Ohio might see a surge maybe in the middle of April to late April. So the policies have to set up how to set up getting ready for the surge, which floors which you can convert into ICUs, which are COVID floors. So that's a very important task for the hospital ICU task force to look at. All elective surgeries are postponed, as was so as to save the PPE. As we all know, there's a shortage of PPE throughout. So, and then you have to come up with the PPE recommendations. Initially, the full mask, N95 mask and gown was used when you're taking care of patients who are COVID positive or who's a person under investigation. But as it became more apparent that COVID could be spread through, or the virus could be spread through the airborne, So we have gone to universal masking actually, which is starting soon. Within the UC Health, every employee will need to use the surgical mask at all times, and this applies to every single UC Health employee. Visitation policy has to be set up. You don't want everybody to be walking in the hospital. So the patients who come to the hospital, they only can have one person accompanying them. Again, you want to decrease the spread of the disease, and that's the reason why we keep doing this. And then finally is the surge. We are really looking at the surge, how to do the surge control. So you have to look at the models, like what kind of models can we set up for that. If you look at the Society of Critical Care Medicine, they gave this tiered model of staffing strategy for the pandemic. If you look at it, so all the employees or all the physicians and the physician assistants, nurse practitioners, they were sent a survey and looked at like what exactly they can do and what kind of skill sets they have, what specialty they do they belong to, and what can they do. Can we go back to the previous slide, please? So there's a different tiered model, which would include a tier one. Tier one is the ICU physician at the top who runs the whole thing, because they're the intensivists, they can control, they're running the ICUs on a daily basis. That's the tier one staff. The tier two staff is, again, it could be ICU physician or a nurse practitioner who have the critical skill sets for taking care of the critically ill patients, but they don't run the ICUs or they don't work as an intensivist on a regular basis. Like you can look at anesthesiologists, the ER doctors, the hospitalists who knows how to intubate the patients, put the central lines in. So they have critical skills, but they don't run the intensive care units on a regular basis. Tier three would be the people like the physicians who don't do critical care work every day, but they might have some exposure to the ICU rotation during the residency or fellowship. So these tier three physicians, they really don't need the skill set to intubate the patients or run the ventilators. They'll be working under the intensivist. And the tier four is the reserves. The reserves are the people who don't fall in any of those categories. And they would be called on if we are really in a pinch. And like in New York, you see like all the healthcare systems are overwhelmed, and at that point in time, we'll call the reserves in. Can you go to the next slide, please? So GME, that's the graduate medical education. Being an educational center, we really have to take care of all our medical students, the residents, and the fellows. So how do you deal with that? The GME actually sends out a email every day, and what they are doing on a regular basis. They did send out a survey to look at which residents and fellows, because you have to look at their education too along with that. Can they be taken off some rotations, and are they available if the surge happens? Especially the fellows who are already trained physicians and they're doing a fellowship. So those are the fellows, and most of them have some exposure to critical care. So those fellows will be used as independent physicians if the surge happens. Communication is the key. They send out a communication every day, and I think the communication is the key to all these things. Even the inpatient task force, the CEO of the UC Health, everybody sends out an email every day, which is great. All the medical students were off clinical duties because we can understand the medical students are still medical students. They're not practicing physicians, so we wanted them to be out of the way. And then we know which residents will be used in surge and where they'll be used. Sending out like what will the tier one residents will be like, who have trained in anesthesia, emergency medicine, critical care. Those are the people who will be at the forefront. The wellness program. In this stressful situation, the wellness program is one of the most important things which we are propagating. And can you go to the next slide? So this is a CARES thing, which was actually written by, this was developed by one of the psychiatrists who's actually my wife, so I have to write it up. This is really a good one. We are giving it to, we are encouraging all the employees to use this. And you can even make a copy of it, send it to your patients. So connection, we do need social distancing, but does not mean that we neglect the social bonds. Do stay connected with your family, with your friends, which could be Zoom, social media. And you all remember this, we are all in this together. A is avoid overconsumption of news. We see you open any channel, it's all about COVID. So stay updated, but not get immersed into the news, which can be really very stressful sometimes. Routines. R is for routines. Maintain your routines every day. Wake up at the same time. Follow regular sleep schedule, regular meal times, daily showers and fresh clothes. It's very important for if you're working at home, you tend to lose your daily routine, and that becomes again another stressful thing. Exercise daily in some form. It's a major stress buster. You know, it could be walking, it could be aerobic exercise, it could be strength training, dancing. And the stress management is very important, which you can do. Everybody has different stress management skills. You can do daily meditation, yoga, prayers, reading, hobbies, whatever you want to do, but take care of it. I'm going to end with this, but we all are in this together, and we know we are running a marathon. It's not a short sprint we are running. Thank you.
Wonderful. Dr. Malinowski? Dr. Malinowski,
thank you very much, Dr. Sachdeva. Yep. Can you hear me now?
Sure thing. We got you now.
Oh, great. Thank you. So I was asked to present based on the perspective of a regional rural medical center and what it's like on the ground level there and what we're doing in response to the current crisis. So next slide, please. So just a quick disclaimer, I don't speak for the healthcare institution. I speak solely based on my opinion as an individual practicing provider in the state of Ohio, working for a healthcare institution in Southern Ohio. So who are we? We're a regional medical center. We cover a large swath of Southern Ohio, specifically many, many counties as listed here in this slide. We touch as far as sharing patients with Columbus and Franklin County, as far west as and southwest as the outskirts of Cincinnati, Dayton, and Springfield. As far south as Southern Ohio, as far as the river goes, the Ohio River, and as far west as West Virginia. So, you know, with that comes both benefits and also concerns when it comes to managing crisis. About our center, we have a spine center, five interventional physicians, a spine surgeon, neurology, and sports medicine. All of us work together to create the spine center and pain facility. So from the perspective of what happened locally, we'll compare it against the cases in Ohio and the timeline that a lot of us already know. You know, February 4th was an important date. That's when we started receiving word from the Ohio Department of Health and their initial alert on the crisis that was occurring not just overseas, but beginning to occur in the United States. In February 28th, there was a CDC health update, and at that, very much nearby that, in between those two particular dates, Ohio saw its first case. But locally, and our main campus is located in Ross County, we still saw no cases at this point in time. Fast forward to March 1st, the healthcare institution initiated their currently existing COVID algorithm. Soon thereafter, March 12th, not only did we see 314 cases jumping from literally just one, still no cases in Ross County, but ultimately the healthcare institution initiated a provider-wide, employee-wide, personal and business-related travel ban. By March 21st, the cases in Ohio ballooned to more than 1,500, and Ross County started to see their first 3 cases. Soon thereafter, March 18th, we ceased all elective cases, injections, and otherwise surgical procedures by end of business day. And by April 3rd, the cases in Ohio nearly doubled, with an uptick by 1 in Ross County to 4. So with this, it appears as though our healthcare institution had a nice lead time, although time is precious under the circumstances, as you can see, the quick ballooning of the cases that are confirmed in the state of Ohio. So the institution established an incident command, which began several weeks ago, and they are meeting twice a day, 7 days a week, and they are around the clock taking call for concerns related to this epidemic. What was important with the healthcare institution is that we established training and a common voice and preparation as a common body of providers. locally. So the healthcare institution began a robust education process, not only about the protocol, but also the COVID pre-exposure protocols, as well as post-identification protocols in caring for these patients. There were aggressive town hall meetings, daily email updates, so that the entire population of our healthcare institution remained as much as possible on the same page. We also had to refresh our PPE training protocols and make sure everybody is using it correctly and the order at which you don and doff and so forth. And in anticipation of what we all know as a statewide work from home situation, we needed work from home tools. So our IT department was aggressive in creating almost a weekly update on those tools and abilities for those of us who are usually in the trenches and in the clinics and in the surgery suite in the procedure room to somehow learn how to function from the home environment. We also needed to establish the security of our people, our structure, and our resources. So this incident command established a COVID screening clinic that not only is drive-through, but as well as a bricks and mortar place that people will go. And once identified, there is a quarantine inpatient cohort unit of just COVID-19 ready providers in the unit itself. They also needed to assess a daily inventory and supply chain. The supply chain, as we all know, is challenged, not just in Ohio, not just locally, but across the United States. So we need to be very conservative. You know, as a regional rural healthcare institution, we're not flush with the ability to maintain large bulks of things, and we do rely on a supply chain to maintain our weekly and monthly resources. So moving forward, so let's talk about the challenges of this current situation just on the ground level. You know, we have patient care challenges as providers and the business of medicine challenges, not only as individual providers, but also from an institutional standpoint. You know, with respect to our patient population, we deal with patients that are very wealthy and rather metropolitan, to a patient population that honestly may not know how to work a computer and quite frankly may not even have indoor plumbing at this point, even to this day in the 21st century. So we take care of a lot of people from a lot of walks of life, and we take great pleasure in the cross section of Appalachia that we take care of. But that comes with challenges when it comes to telemedicine, and patients were slow to adapt. They're used to getting face-to-face with the provider, speaking on a common level and creating a plan together, and that's not always easy over the phone. We also were faced with the challenge of how do we take care of healthy patients? You know, under the circumstances, we're still going to have people at home spending time with their families, trying to get out into the yard, playing kickball, playing volleyball, and having natural injuries, back injuries, ankle injuries. What do we do with these patients? Do we mix them into the ER with other possible COVID patients? So we had to create a healthy patient walk-in clinic to deal with that. As an interventional paid provider that does provide intrathecal drug delivery care, we had to figure this out, and we are still on a rolling basis determining how we're going to handle on a case-by-case basis people that may need to be outsourced to a third party to fill their pumps versus ongoing care individually with patients that are still considered well based on screening standards. That's also important because we have to determine when these pumps come to end of life or near end of life. We need to make a decision on who's going to get a pump replacement versus who's we can, and for lack of a better way of putting it, drag it out maybe another week or 2 weeks in hopes of the curve to be suppressed. We also know that there's a company out there that has supply chain issues, which does compound certain matters under the circumstances, but I know that company is working hard to rectify the situation. There's also, you know, the question of how to plan for normalcy when and if that occurs in the near future. And that trickles down to recurrent visits and how to handle, you know, planning for follow-up, medication management as appropriate, and prioritization of care when we're able to start planning interventional procedures and surgical procedures. And those patients need to be, for lack of a better way of putting it, triaged based on importance. And then ultimately, as paid physicians, you know, there are several of us at our healthcare institution that represent anesthesia. Some of us represent PM&R. We have different skill sets, but still important. We may be reallocated, and we will be reallocated to the floors and to the ICU into the surgery suite to be the next wave of immediate care providers once the initial wave absorbs the care the care of the population that could be rapidly upticking. So ultimately, from the standpoint of the business of medicine, we have a lot to consider. We do have to strongly consider the nature of prior authorization expirations. We need to consider a number of different factors. Can you go back to the previous slide, please? And just briefly, moving forward with one important thing that I do want to make the point, which is when we do return to normal, will we have the same colleagues, our right-hand caregivers that we're used to in the trenches, doing the authorizations, doing the patient care, creating the scheduling? Will we have procedure room nurses? Will we have the same nurses? We just don't know. There's been reallocation, furloughs, and layoffs that are playing a strong consideration of when we do come out from this horrible crisis. Who are we going to be shoulder to shoulder with? So that is an important thing when you're reaching out to people that you have business-related friendships with, to care for one another and share experiences and encourage one another to come back to the table and function as a normal unit. So next slide. Thank you very much. Please, everybody, stay healthy, and please stay around for a question and answer session after this presentation.
Thank you, Mark. I'm Rick Bonaventura. I'll be talking about telemedicine. I'll be talking about it more from the small office approach. Next slide, please. Just a quick introduction. I'm an anesthesiology-based pain physician. I run a small practice in Dayton, Ohio, myself and 3 staff members. And as this COVID-19 pandemic was developing, I could see that telemedicine was going to be important, and I tasked my staff members, Cheryl Spang, and who's speaking next, and Mandy Hummerick, to figure out how to optimize this as quickly as we could and as efficiently. And so I'll get into that, but first we're going to go over telemedicine. So telemedicine, that's the practice of caring for patients remotely when the patient and their provider are not physically in the same location. Telemedicine has been around, and it was mostly meant for providing services to underserved populations or rural populations, and also to bring specialists or types of care to the community that otherwise might not be readily available. You can think of mental health. I've had patients tell me that they meet with their counselor through telehealth visits, and this was months ago, before the pandemic started. So now with social distancing and an effort, we want to keep people home and decrease patient traffic through our clinics, but also decrease traffic outside. So telemedicine has become an important way of doing that. So we can, again, just minimize our interactions, at least physically, with other people. So next slide. So 1135 waiver, you might hear this phrase. 1135 waiver is a waiver that it was in existence before, and it was essentially a law or rule that would allow the president or the Secretary of Human and Health Services to make changes to be able to move goods or healthcare items or healthcare services throughout the country or to a special area, a certain area if there was a problem, and also to make a good faith effort to reimburse those providers for providing that care and exempting them from sanctions if they're, so to speak, cutting corners. And President Trump did enact this in the middle of March. With that, telemedicine, came to the forefront for the way we were going to treat people. You stay there. The 3 types of visits under CMS. So these are CMS or Medicare guidelines for telemedicine and the waiver, under the waiver. They created 3 different types of telemedicine visits. Important to remember when you use the term telemedicine, at least in the Medicare guidelines, telemedicine is the umbrella term. I think it's steroids, and then underneath it, there's different types of steroids. Well, there's 3 types of visits. A telehealth visit, which would be a visit that includes audio-visual communication. So for a variety of providers can provide that. Previously, there was supposed to have been a pre-existing relationship before you could do the visit, i.e. you can only use it for established patients, but now with the 1135 waiver, you can use it for consults. Virtual check-in, again, unfortunate name, it really should have been telephone, keep it simple, but it's virtual check-in, and it's for a brief communication, usually it should be more than 5 minutes, and in this case, there again, it's expected that there's a pre-existing relationship, but given the fact that some people don't have access to computers, as Mark just mentioned, you can use these for consults as well. E-visits, electronic communication through a patient portal. So this would be electronic messaging, and they pay based on the total time spent over the previous 7-day period. So if you got a whole bunch of emails from a person or messaging through my chart, and you spent between 5 and 10 minutes answering those over a 1-week period, you can bill a certain code level. And if it's more than 10 minutes, you can bill another code level higher. And then if it's more than 20 minutes, it's another code. Next number, or next slide rather. So prerequisites for a telehealth encounter. So this is important because you should somehow document this in your charting. So figure about putting this as a smart list or a phrase at the start of your HPI or at the bottom. So basically you want to verify that you're speaking with that patient, the correct patient, and not a family member. If you're talking on a telephone, again, you need to make sure that that's the patient. The patient should give consent to and initiate the telehealth encounter, and that could be agreeing to an appointment time and an agreed upon appointment time. They don't necessarily have to call in with this waiver now. The service must be medically reasonable and necessary. The services should be performed by a physician or a qualified healthcare provider. The time spent in the discussion should be documented, and it really should be more than 5 minutes, because otherwise some of these codes, they wouldn't pay you if it's less than 5 minutes. And most importantly, you want to document the means of service. Was it an audio-visual visit? Was it a telephone visit? So types of telehealth platforms, and this is audio-visual. And this information came from another webinar that I participated in about a week and a half ago. And basically we just polled the attendees and asked them, so what type of service are you using for audio-visual telehealth? Is it a subscription or fee-based telehealth service? These were in existence before this public health emergency, and SnapMD and Teladoc are some famous ones. So a free telehealth service, that would be something along the lines of DoxyMe and some of these other ones listed there. Video conferencing apps would be Zoom or Jitsi, and then video chat apps, FaceTime, Google Duo. You can see that most of the people that were on that call, or a large portion of them, were using the free telehealth service, such as DoxyMe. But a significant portion were using other apps, such as conference apps like Zoom or chat apps like FaceTime and Google Duo. We happen to be using Google Duo. The reason we chose that is because FaceTime only works across iPhone technology. Google Duo would not. And we chose that as a way to get to all patients using Android phones or iPhones. And actually, when we started calling them, it turns out a lot of people who had Android phones were already familiar with Google Duo because they were using it because of social distancing to keep in touch with their families. Next slide. So how we adopted telemedicine in our private office. As I mentioned, some larger universities, health centers, health systems rather, hospitals, they're probably already using some system that their IT specialist told them to use, or should. But for small offices, small private practices and groups, you got a lot of flexibility here, and you can take your time to pick and choose which ones work for you to get through this or get something up running very quickly and cost effectively. The HIPAA waiver is effective through at least mid-June. It allows you to use any audio-visual communication, and there's no concern for HIPAA compliance. I mentioned that we settled on Google Duo. It's free. It's not HIPAA compliant. The patients were very familiar with it, so it was easy to hit the deck running and get going with this really fast. We got going with this before even Governor DeWine essentially shut down non-essential businesses. We're up and running with this half a week before. DoxyMe is partially free, it's HIPAA compliant, but it's a little more difficult for patients to use. It requires significant bandwidth. There could be difficulty with the connections if the patients doesn't have, again, significant bandwidth on their internet service provider at home. Next slide. So telemedicine using Google Duo and ER from the home. So I use, I'm a solo private practice physician, but I am able to use the EMR of one of the 2 health systems here in Dayton, Ohio, and I can still access the other systems, Epic as well. So I can access that from my home. So I have this computer that I can use to access the Epic, and then we've set up an iPad from the office with Google Duo. Google Duo is an app you can download, put it on the iPad or phone, and then you can link that to one of your phones in your office. The patient would have to call through the Google Duo app to that phone number to show up on that conversation. If a person calls the phone number to your office, they're not going to pop up and interfere with the Google Duo. So I have a staff member that works with me with this, and she's set up the Google Duo on her phone, and she can set up essentially conference calls. She can call the patient from her phone and then call me on the iPad phone. And she also has one of our office phones numbers or phone lines sending calls to her phone. And then she can, again, she's loaded that up in the Google Duo app, and then she calls the patient on the Google Duo app. They have to download it and be prepared for the call. So again, she arranges it on a pre-scheduled time. The patient's not calling in. She checks them in, gets them ready for the visit, and then turns it over to me. I'm talking to the patient on the Google Duo app on the iPad next to my computer, where I'm looking at Epic, and I can pull up the entire chart. I can see her visits with her primary care provider. I can look at MRI reports from that health system plus the other system, and I can pull up pictures from the hospital for which I have full access to, and I can do all of this at home on my computer. Virtual check-in, we've used that for some people that just have no interest or ability to get on Google Duo, so we do use that on occasion. My staffer will call them on, again, her phone, her mobile phone, using the *67 to block the ID. And then again, she sets the call up, calls me, and then we talk and go on. Physical exam. So you can do the advantage of the auto-visual, the full, is you can do a physical exam and you can bill for an E&M code. You have the patient set the phone down somewhere or have a family member hold the phone and just point it at them. And then you can talk to them through the speakerphone on the phone and have them walk across the room. You can have them tiptoe and do heel and toe walk, and you can assess their range of motion of the neck and lumbar spine. I even have them sit down and do Strelig-Raisen test and Patrick's test. And then also you can just assess their overall appearance, the general appearance of skin color, any sign of a skin rash or a respiratory rate. Next one. Next slide, please. Also, this we just figured out today. We were sending patients our questionnaire, our pain questionnaire, via email or phone. But then how do patients get them back to you if they're at home too and they don't have a home office or fax or scanner? Well, we figured out we would create a survey and send them the survey and fill it out. So we basically put the first 2 pages of our pain questionnaire, which would be, when the pain started and the typical, how they rate the pain and the quality of the pain and what makes it worse and if there's red flags. We put that on a Google Forms document and send that to them, and they fill it out and send it back. So, and it's free. So last details to close up the office. If you're going to switch to telemedicine, you don't have to go to the office anymore. So you can stay home for 4 days out of the week and go to the office maybe for a little bit of work or to see those emergency patients that you really need to see or perform a procedure if need be. So the office will be closed for a large portion of the day. You're going to need to put signs on your door saying, that the office will be closed and open only for irregular hours, and a person should call if they need to get to you. You want to figure out how to handle the mail. The mail is going to need to be either sent to someone else's home, yours or your office managers, so that they can keep track of checks that are coming in and EOBs that they can enter and balance the billing. As I mentioned previously, you're going to switch over the phones too, so that the phones can be managed by another assistant who can then log on to Epic on their computer at home, and they can enter in appointments and send messages to you, which you can check on your Epic at your home. And I mentioned about the signs. So the other thing is, if you have a mail slot on your door, well, that's great. But if you don't, other thing you can do is basically put a temporary mailbox. So you can buy a mailbox at the hardware store and just put it up on a post and put it in front of your door. Next slide. And that's it. So that's a picture of me on the iPad. You can see the Google Duo app there. And then just to the right of the screen, you can see a little bit of the Epic frame there. I cropped it to cut off the names of the patients and referring docs. But that's sort of my setup. And there I am in my bedroom. So it's easy to do. You can do it very quickly with some apps that are easily accessible and free. So now I'm going to turn it over to my office manager, Cheryl Spang, who helped me set up the telemedicine, but she's also doing the billing for their office, so she can give you some a little bit of tips from our experience in our office. So I'll turn it over to her now.
Hello, everyone. Thank you so much. My name is Cheryl, and like Dr. Buenaventura said, I'm the office manager here at Pain Relief of Dayton, and I'll be talking to you briefly about just some basic coding guidelines for both CMS and then your commercial payers, and then also just some tips that we have come across and noticed while we're working our way through this. No doubt many of us don't have extensive billing experience with telehealth codes. That's certainly been our experience. And so really a lot of this is a learning process and a lot of trial and error. So when you're coding for a CMS Medicare claim, make sure you're going to code for the service that you are performing. So if you're doing a telephone call, then you want to code for that virtual check-in. Don't bill a telehealth visit if you're not having that audio and visual components, okay? There was a question at one point, the site of service with CMS, they were recommending that you code an O2, which would say that you were billing from your home if the physician was at their home. That has changed, and I do have the link there on page 15. You can see where that has changed, and now we're going to be billing that just as site of service 11. There was also a question of, does the physician need to contact CMS and give their home address as a site of service? I actually contacted CGS. They have created a hotline. Each MAC has their own hotline for this COVID pandemic. I contacted them to say, hey, I want to add Dr. Buenaventura's home address so that we can bill these claims. And I was told that it was not needed. So we have not actually done that. We're just coding them as an 11 for the office visit. So a large portion of our claims, they're really just being coded as a telehealth claim. We are trying to push all of our patients to do the Google Duo. If you can make all of your claims kind of one thing, it will really infinitely make your life easier with billing. So for a telehealth claim, we're going to code our E&M code, place of service 11, and we're going to use a modifier 95 on that. We're trying to not do really any e-visits, and we're doing as few phone call visits as we can, only for those folks who either just can't work the apps or just really don't want to. Next slide, please. So your modifier options, there's a GT/GQ modifier. I don't see for us as an independent office that we really would have any reason to use either of these modifiers. We have been using just the 95 modifier really for all the claims that we've sent out, CMS, commercial, telephone, and telehealth. 95 is just going to indicate to the payer that you are using a telemedicine service that has both interactive audio and video telecommunications. We have received some claims back already from commercial payers, and they are paying just fine. We have not run into any hiccups as of yet. Our CMS claims are still kind of out there. CMS has, or CGS rather, has them. They're being processed, so it remains to be seen. Next slide, please. Commercial plans, these can get a little tricky. almost all plans, commercial plans, have dedicated COVID-19 sections on their websites. And they are very good at indicating if they have special requirements and how they want their telemedicine visits coded. I would really encourage you to familiarize yourself with this information. And I know there's a lot of emails floating and bouncing around and people are getting different information. Just be cautious of what information, where it's coming from. Go to the source. So if you're not clear on what United Healthcare is wanting, go to their website. It will spell it out for you. If you're still not sure, give United Healthcare a call. Okay, they're going to help you out. Again, we've been using Place of Service 11 and Modifier 95. Again, no problems. We've had a handful of claims come back paid just fine. Be aware that copays, coinsurance, and or deductibles do apply for our visits, and these really should be collected at the time of service. When all of this stuff started coming out about accepting of telehealth claims, there was a lot of talk about, oh, we're waiving copays for this. And really, that's only for if they're being seen because they have COVID-19 or they're suspected to have COVID-19. If they're just doing a regular family visit follow-up or a follow-up with Dr. Buenaventura for a SI injection, maybe they had one 3 weeks ago, they're still going to have to pay that copay. Next slide, please. And I should touch on the commercial. I think Anthem just came out with a list of kind of how they want things coded, and they have their telephone calls. They've said that they want the codes that really are the e-visit codes. So there's a lot of misinformation out there and things that aren't really clear. So again, if I were going to bill an Anthem telephone call, I would probably call Anthem and say, hey, is this really the code that you want? Because the code you're telling me is an e-visit code, not a telephone code. So just as a follow-up, telemedicine billing, it is going to be a trial and error process. So just kind of be aware of that. Follow up on your claims frequently and often. This is really important. You want to stay on top of this. Your reimbursements are already likely going to be lower because you will probably have a lower patient volume, so you don't want these to get out of hand. You should be checking, has the claim been accepted by the payer? Most payers have portals that you can log on, or you can log on through things like Availity. Is the claim in process? Has it maybe been held up by your clearinghouse? You want to get all those errors fixed as soon as you can. If the claim is denied, you want to get that appealed immediately. We all know that insurance payers deny claims constantly. This is going to be no exception. I would recommend to have an appeal template ready. That way, when you get these, they can be sent off immediately. Next slide. If you have any outstanding AR, which we know that we all do, now is the absolute time to be working that. Your patient volume is going to be down. This is a really great way to work the AR, increase some revenue, get some claims paid that have been outstanding. If you're able to spare a staff member to work at home and get these worked out, it will really help you. And that is all I have, guys. Thank you so much. I appreciate you letting me participate.
Thanks, Cheryl. I'd like to introduce Dr. Escobar.
The coronavirus outbreak continues to challenge our nation, and we have yet to feel the full impact of this global pandemic. We as pain physicians need to help prepare locally for the increase in COVID-19 patients and the precautions we can take to mitigate viral spread. During this current pandemic, hospitals and individual providers face increasing difficult decisions, with each individual specialty scrambling to create guidelines for their respective fields. As we know pain to be a subjective experience to an actual or potential tissue damage, many argue that all pain procedures are elective, while others deem access to pain treatment as a fundamental human right. In view of this global crisis, by no means are we trying to push an agenda nor advocate for the utilization of interventional therapies above other specialties, but merely support the proper risk stratification and treatment of patients dealing with pain during these unprecedented times. Nothing supersedes sound medical judgment, and thus it is generally advised that if an intervention can be postponed or delayed, it should. However, what do we do when we have a therapy that can address a particular pathology and avoid further healthcare utilization? That decision to proceed with an intervention in today's climate should be evaluated on a case-by-case basis with a dedicated COVID surgical committee that triages these cases accordingly. This shared decision-making requires strict adherence to state regulations, awareness of the local impact that COVID requires, with an individualized action plan for each. Tonight, I will focus on the state of affairs in Ohio, which has been quite proactive in implementing a local policy to embrace for what's to come. But make sure to refer to your local, state, and federal policies. Now, as an anesthesiologist, it's hard not to see the irony of our Surgeon General's early recommendation to cancel all elective cases. Initially, this was felt to be very drastic, which left us all wondering how to address our patients in our practice. This rapid response continues to be a fluid policy that will likely see many changes that continue to mitigate during the spread of this virus. Tonight, focusing on the state of affairs in Ohio, which has been very proactive in implementing a local policy. We'll look at Ohio. Next slide. Ohio's Department of Health issued a state order to cease and cancel all elective and non-essential surgeries, making criteria pretty detailed in Section 2. However, we see in Section 2D, the rapidly worsening to severe symptoms is an area that has a significant amount of gray zone. It's clear what the intention of this order aims to do, and that's to ensure adequate supplies and resources to tend to the critical hotspots. Some of these precautions aim to minimize aerosolized generating procedures for asymptomatic carriers, minimize the risk of exposure of the spread of the virus, minimize the use of critical supplies and equipment that can be redirected for more acute patients, blood conservation, staffing requirements, ICU and inpatient bed capacities, which will all have direct impacts for hospital-based practices. And as Dr. OHSIPP mentioned earlier, in Toledo, we do have a designated COVID hospital, which is ProMedica Hospital Bayside, that's located about a mile from our practice. Now, how do we define rapidly worsening to severe symptoms? This can greatly vary from physician to physician. It's essential that we all do our part to flatten the curve while only performing emergent to urgent cases on a case-by-case evaluation. Take in mind that emergent and urgent nature of cases will change as the local impact of COVID worsens, especially in hospital settings. Next slide. One slide back. So American College of Surgeons have all been pretty clear with each specific specialty delegating what they feel are urgent to emergent procedures. And in particular, the breast and colorectal specialties have classified each of their cases statuses based on the following phases. Phase 1 being semi-urgent, which I feel we are no longer in. Phase 2 is the urgent setting, where we're seeing many COVID patients with increasing burden on our ICUs and ventilatory capacities. And then phase 3, the disaster setting, when we have identified a hotspot. Now, obviously, many of our cases will cease once that disaster phase occurs. However, in our practice, we've implemented a care set to identify the role and the justification of proceeding with the procedure. This is reviewed by a surgical COVID committee that's including of anesthesiologists, surgeons, and nurses. Next slide. Within our practice, we've suggested some examples of case triage by defining procedural classifications to emergent, urgent, elective, and non-urgent, which can be argued across many professionals. Looking at more emergent cases, any type of implantable pain therapy that has malfunctioned, whether it's an intrathecal device or a spinal cord stimulator, the use of kyphoplasty to treat compression fractures and deformities, and then blood patches to treat intracranial hypotension that should occur with an inadvertent dural puncture. Now, arguing these as emergent cases is questionable. However, I do feel that these therapies have a high probability to mitigate a patient's pain and reduce the burden of that patient seeking further care at a hospital setting. Urgent cases are looked at as, acute disc herniations that we can offer epidural steroid injections for, neurolytics for cancer pain. Sympathetic blocks can be questioned whether or not they are more elective and non-urgent versus urgent. However, we know that early mitigation of early CRPS can have profound impacts on the longevity of that patient's long-term outcomes. But as we see changes in policy and recommendations, I employ all of you to assume that all patients are potential carriers, and despite screening temperatures and questioning on their recent travel, we will likely miss asymptomatic carriers. Thus, we all must protect ourselves. Despite the concern for minimizing the use of protective personal equipment, when we do deem a procedure to be urgent or emergent, we will be employing the safety and the standard precautions, which include face masks, shields, eye protection, and sterile gloves. In addition, there are some things that we can do to mitigate the contact that these patients have, and that's social distancing and employee distancing, keeping 6 feet of separation, wearing masks throughout all times, and being conservative with these masks, only changing them when they're soiled, and using one throughout the day. And I stress the terminal cleaning of each case and the timing of those cases that are performed, leaving ample opportunity for the room to be cleaned appropriately between each procedure. Next slide. Flattening the curve is something we hear over and over. And what we've seen and found with our opioid epidemic is that we've been successful at mitigating the risks of opioid misuse and abuse. What I don't want to have happen is us as a specialty to revert back to old measures and inadvertently escalate opioid medications or start naive patients on opioids because we're not able to offer other interventional strategies. However, with desperate times come desperate measures, and I do feel like many patients will be victim to this and not be able to be offered modalities that would likely mitigate their chronic pain condition, and medications will have to be used to successfully and proactively address our community. I encourage all of you to be the voice of reason within your organizations and to write letters to your local representatives and congressmen. Only we have the ability to change the course of this pandemic, and I encourage you all to be advocates for the specialty and your practice and do what's right for your patients. I'll turn it over to Dr. Sowen to discuss another important, relevant topic, offset the financial impact that this pandemic has caused us. Thank you for your time.
Thank you, Alex. Great job, and excellent presentation by everyone. We're going to talk about the business and economic impacts and some tips for survival during the crisis. So please advance to the next slide. Options to capitalize your business. Just a quick disclaimer. Ultimately, you are responsible. These things are just my opinion. It's important to consult with a lawyer, banker, and an accountant. So we're going to stay on this slide for a while because for Ohio, basically, we have 6 good options to capitalize your office and your clinic. And this is important to note because a lot of us are going to be suffering some financial strain, especially those in private practice. And if you are in a position where you start to run out of capital or you can't make your payroll, it's important that you have actually take advantage of every single program out there because there's a lot of help out there for physicians, and I just want to make sure everyone's maximizing their benefit. The first one that is really important is the SBA Chapter 7A Paycheck Protection Program that was passed by the CARES Act. As you guys may have heard, the way you apply for this is by contacting your local banker. And if you're a small business with less than 500 employees, you have the ability to take your average monthly payroll, multiply that by 2.5 times, and then you can get a loan for that amount. That's your maximum allowable loan, up to $10 million. Now, once you do that, if you spend that money on payroll for 2 months, as well as you can spend 25% of that total loan on other things like mortgage, interest, rent, health benefits, 401k. it ends up becoming basically a grant from the government. In other words, the loan is forgivable. To apply for this program, it's important to contact your local bank because most banks are registered SBA lenders. And it's important to fill out an application soon because the money is going rather fast. There's only like $350 billion there. It's funny that I say only to that, but that money is going to be, that well is going to dry up very quickly. Within the first day, something like $25 billion in loans went out, and that was before all of the banks were even online. So contact your local bank and look into that program for yourself if you're in private practice because you want to capture that money. Secondly is the disaster loan from the SBA directly. This is different than the Paycheck Protection Program. To apply for this, just simply Google SBA disaster loan and you can find the application right there. One thing I want to tell you is that there is a $10,000 forgivable grant through this program. And if you're in private practice and you have not applied for this, at least at the end of this call, immediately Google and apply for that. Because the way that works is you just fill out some basic information about your practice. I did this, it probably took me only 15 minutes. At the very end, you check a box to be considered for a $10,000 grant. If you get that, supposedly within 7 to 10 business days, you're supposed to get deposited into your business account $10,000 that is forgivable. When you fill out the last page of that, it asks for your bank routing number and your account number to do that. So please do consider to take advantage of at least that program at a minimum. If you do get that $10,000, that forgivable $10,000 from this program, you actually have to deduct $10,000 from your Paycheck Protection Program if you actually get that money as well, as far as what's being forgivable. If you do get the Paycheck Protection Program, there is a payback period for that if your loan is considered not forgivable, but the interest rate's rather low at 1%. The third option is Medicare advance payments. We have a form that I can circulate to you guys on how to fill this out. It is simply one sheet of paper that you fill out for your practice. And what this is essentially is an interest-free bridge loan for your practice. And essentially what Medicare does is gives you an advance payment based on future claims. So there's a formula that you can use based on your previous claims over the last 60 days. You can request that up in advance. Now, when you do that, what happens is they deposit electronically into your account that you have set up for EFT and advance payment from Medicare. You have to pay that back over approximately 210 days, but it is interest-free. And it is based on your future claims. So as you bill Medicare moving forward, when we start to open back up, Medicare will deduct that amount from your future claims, but it can help you with cash flow immediately and it's interest free. So if you're worried about finances, definitely take advantage of that program. It is literally one sheet of paper to fill out. I sent mine out last week. Within one business day, they acknowledged receipt and I heard the money's coming in 7 days. I already talked about the disaster grant of $10,000. However, there is a formal disaster loan program that you can apply for. You can apply for up to $2 million. The payback period depends. It could be anywhere from 2 to 10 years. There is an interest rate associated with that at 3.75%. You have to provide collateral if you are asking for a loan of over $200,000. You have to provide a personal guarantee as well. However, that can also help you. But let's say you didn't want to do any of this stuff, the Paycheck Protection Program, the disaster loan, or Medicare advance payment. There is still a payroll tax deferral program that was announced where you can actually defer your payroll taxes, which can help you with cash flow. However, if you do that, you're just deferring it. You do have to pay it down the road, but that can help out. That program was actually designed for very large entities that can't take advantage of other programs. So this, of course, these SBA stands for small business loans. These are for larger organizations, right? Like hospitals and networks that have very large, robust businesses. They need to take advantage of some program too. The final option is unemployment, right? You can actually furlough some of your employees. You can put them on unemployment if they're not working for you. You can, if you don't have work for them, you can put them on there and they can apply for unemployment through the state. You have to file a weekly claim for unemployment. That's very easy to do. They can just type in unemployment Ohio application, and that's usually the first thing that comes up. The other thing I want to tell you is that the unemployment in the state pays about 50% of the salary up to a salary of $110,000 a year or so. But the federal government is actually also helping out with unemployment insurance. And so if you furlough someone, not only can they get the 50% of their salary from unemployment from the state, there also may be other federal dollars that they're entitled to. So it's actually not a terrible thing to do to your employee if that's a last resort option. So I don't want to spend too much time because we've spent a lot of time tonight on this call. Those are some basic updates. A slide deck here that's got a lot of information about it. I'll try to make that available to all of the members of OHSIPP. And I think Dr. Buenaventura is going to follow up with the follow-up email. And in there, we'll put attachments to some of the forms and links for some of the loan programs for you in this coming week. So I'll turn it over to Dr. Buenaventura, who's going to handle the Q&A. We've been receiving questions throughout this call via text and chat. So Dr. Buenaventura, you can proceed with the question and answer period. Thank you and good night.
Thank you, Mal. Thank you all, to all the speakers. Thank you for listeners out there for sticking with us. We've got a few questions so far. I'll pass the first one on to Dr. Akbeck, and it's regards to the, can you discuss asymptomatic carriers and how long should they isolate? So I'll turn that over to him, and we'll come back after he's done.
Yes, let me handle this question. I'm just going to read it. How long should they isolate? Now, we know from the studies that it showed the time of the infection, the symptom starts about 6 days after, and it takes about 6 days to really manifest itself. So you really need at least 12 to 13 days, and that's where the 14 days rule came from, that if hour 0, 6 days to start, really start showing some symptoms, and another 6 days to manifest the full symptoms. And also, how long do you restart them, and do they need medication to eradicate? Now, I am not gonna, don't take this as a rule, but from what we have looked into other models, France, Italy, Spain, Germany, Korea, China, all of them, the minute they are positive and symptomatic, they get treated. Remember, about 36 to 40% of people can be carrying the disease and asymptomatic. But when you start showing symptoms, that's where they get treated. So they get tested, they're positive, they're symptomatic, they get treated. I don't know if I answered the question.
Thank you. So next question is for me. Basically, which Google apps did I use? One of them was in the slides. It's Google Duo, D-U-O. And that was the app for basically video chats. And then the other one that I mentioned was for converting your pain questionnaire, into a survey type setup that the patient can just fill out on the internet. And that's Google Forms. Both of them are free and very easy to use and very easy to set up. Next question is for Cheryl, and that one was related to, how high of a level of evaluation and management code can you use during telehealth visits? And I'll turn that one over to her.
All right, can you hear me? So I think the question was, can you, at any time during a telehealth visit, code a 1-4 or a 0-4, so basically a level 4? And the answer to that is yes. We have actually coded, and let's see, I'm actually looking at it right now. It was a 99204, and we did receive payment for that. And the thing that you need to remember with any level, you just need to follow the basic guidelines up for that level. So for a level 4, you need a history, you need a physical exam, and you need some medical decision making, typically on 3 or more problems. Our new patients They're filling out a complete history, and that is reviewed with the patient during the visit. They are getting a physical exam, albeit maybe not as complete as if they were in person, but Dr. Buenaventura will have them kind of set their phone or their tablet up. He'll have them walk to assess their gait. He can have them do Patrick's and kind of assess what's their flexion and extension like. He can have them do different range of motion movements, so that can satisfy that. And then, of course, they're making those medical decision-making decisions. They're talking about prescriptions. They're talking about different activities and exercises and PT, and do you need an MRI, and here's what we can do in the future. So as long as you're checking these boxes and you're documenting that you're doing it, you can code a 4 just like you would any other time. I would caution you that not every visit you do should be a 4. You certainly don't want to raise any red flags for yourself, but if you're doing the work for a 4, then yes, you can code for a 4. That's all I got.
Okay, and with that, it's 8:30. We're going to go ahead and end it there and thank everybody for signing in, and thank you to all the speakers. I think it was a very great, informative talk. This will be recorded and posted on Paincast as well as OHSIPP websites. I want to thank you all and remind everybody to be safe and stay healthy. Goodbye.